all of you. And KSOGA, the dynamic organization, brings you the second episode of the Clinical Research Committee webinars. Today, I think there is a lot many new things to learn. Both the sessions have been very well planned by Dr. Srimati and Dr. Jyotika Desai, and we have Dr. Sundari also here to judge the speakers on this. So all the very best to all the speakers, and a very warm welcome to all the audience, and especially to the expert, Dr. Padmarekha Jirge. Over to the President, Dr. Durgadas.
Namaste. Welcome to all. Special welcome to Chief Guest of today's evening, Dr. Padmarekha Jirge. As our Secretary, Dr. Shobha, has rightly told, today is the second episode of the Clinical Research Committee, and this is going in a good way under the able guidance of the chairperson of the committee, Dr. Srimati Raman, who has been guided regularly by Dr. Jyotika Desai. Now, I have to tell something about Dr. Srimati Raman's commitment about today's event. After the last episode, Srimati underwent a major surgery with a turmoil post-op recovery. In spite of that, in spite of her health issues, she has come out with such an excellent program today. Of course, needless to say, she has been guided and supported continuously by my beloved Dr. Jyotika Desai. This is the sanctity of the event today. Now, another one thing I have to tell about Dr. Padmarekha Jirge. Really, madam, we are honored. I know you are an excellent academician, excellent teacher, more than that, excellent human being. KSOGA welcomes you for today's evening. I conclude by congratulating today's 4 speakers, and they are Dr. Varshita from Davangere, Dr. Deepthi from Bangalore, Dr. Bhavya from Hassan, and Dr. Sangeeta from Bidar. Best of luck to all of you. Thank you.
Thank you, sir.
Thank you, sir. Thank you for your kind words. Sir, we missed the lighting of the lamp. Shall we do it before starting the... Yes, sir. Arun?
Oh, I'm sorry, Srimati. I'm very sorry. Please
it be
go
the
ahead.
first event. Okay,
Yeah,
let it be. Invoking the God is very important.
Yeah, please do it now, please.
Arun, can you please do it, Arun, before we start?
Kurutvam kalyanam arogyam dhanasampadah shubham tvam kalyanam arogyam dhanasampadah shatru buddhi vinashaya deepajyotirnamostute deepajyotirnamostute.
Thank you. Thank you, sir, for your kind words, and I thank Jyotika ma'am for being behind me every step, hand-holding me. So it's indeed a great pleasure, and I thank sir for having given me this opportunity. And of course, Shobha Gudi ma'am for helping us out. So I would just want to briefly introduce the judges. So Jyotika ma'am and Sundari ma'am are going to be the judges of the webinar series. Jyotika ma'am needs no introduction. She's the advisor for KSOGA, advisor for the CRC committee. Ma'am is a senior consultant at PR Desai Hospital, past president of BSOG, excellent teacher and excellent achievements. I don't think there is any KSOGian who doesn't know ma'am. Sundari madam, she's also our webinar series judge. Ma'am is currently honorary professor at SMSI MSR. Ma'am is a great teacher, a humble human being, and who inspires us to follow in her steps.
Srimati, please, no.
Ma'am, that is all I'm saying, ma'am. That is all
No,
I'm
ma,
saying.
don't waste time on that.
Yes, ma'am. And of course, our special chief guest, Dr. Padmarekha Jirge, madam. Thank you very much for joining us, madam. Madam is the scientific director at Shushruth Assisted Conception Clinic and Shreyas Multi-Speciality Hospital and Research Institute from Kolhapur. She's also the founder director of Prismatic Research Foundation, and she's got lots of publications to her credit. And she's the president of the Fertility Preservation Society of India. It's indeed a great pleasure having you as a judge, as well as to give the expert talk. Thank you very much, ma'am. And the 4 speakers for today who have been selected by the society: Dr. Varshita from Davangere. She is a consultant at Alur Fertility and IVF Center, and her special areas of interest are tackling recurrent implantation failure and poor ovarian responders. It's a great pleasure to have you, Dr. Varshita. Dr. Bhavya, who is a past secretary of Hassan. Sorry, Dr. Deepthi, can you just give me a minute? I'm just sharing. Dr. Deepthi, I'm just going to finish mine. Yeah. So Dr. Bhavya, who's a past president of Hassan OBG Society, and she's a medical director at Shriya IVF for Women and Child Health Care Hassan. Then we have Dr. Deepthi, who's from Ma Fertility Center, Yelahanka. She has got both specialization in fetal medicine as well as in reproductive medicine, and she has had 10 years of experience as an infertility specialist. And then we have Dr. Sangeeta, who's an assistant professor from BRIMS Bidar, and she's been the she's past vice president of IMA at Bidar and also the joint secretary OBG Society Bidar. So thank you very much for joining us. So we just to again reiterate the rules. So we have 12 minutes for the talk, 3 minutes for the question and answers. Please stick to the time limits, and 3 minutes for the Q&A, which I will inform at the end of 3 minutes. And for your talk for the 12 minutes, at the end of 11 minutes, I'll give you a warning that 1 minute is present. I hope the way the webinar is going to be connected is clear. So with the permission of the judges, the president and the secretary, can we have the first speaker, ma'am?
Yes, Srimati.
Yeah, please go ahead.
So for the first speaker, it is going to be Dr. Varshita. Yeah. You're ready with your slides, Dr.
Yes, ma'am.
Yeah, go to the first slide.
Yes, ma'am.
Yeah, on slideshow, please.
Yes, ma'am.
Yeah. Ma'am, can she start, ma'am?
Yes, please.
Yeah.
Good evening, one and all. At the outset, I would like to thank KSOGA Clinical Research Committee and Davangere OBG Society for giving me this opportunity. Today's topic would be recent trends in ovulation induction. So induction of ovulation means development of single follicle. And when I say superovulation or ovarian stimulation, it means development of more than one follicle. What are the aims of ovulation induction? To combat oligoovulation, to achieve development of single follicle, to minimize adverse effects like OHSS and multiple gestation. It has to be least invasive, cheap, simple, and mostly easily accessible to all our patients. Before we go into management protocol, let us understand two important physiological concepts, that is FSH threshold and window concept. Threshold concentration is that concentration above which there is recruitment of dominant follicle, and window is the time during which FSH concentration remains above the threshold concentration. So these two concepts are very important when we tackle ovulation induction or ovarian stimulation. Before we start any ovulation induction, we have to treat associated causes, any other additional causes such as hyperprolactinemia, thyroid dysfunction, hirsutism, and virilization. Any obese woman or overweight woman comes to us, and when we start ovulation induction, first foremost strategy would be changing her lifestyle, because even 5 to 10% of weight loss will restore her ovulatory dysfunction. Coming to ovarian stimulation protocols, we have clomiphene, letrose, CC plus gonadotropins, letrose plus gonadotropins, and antagonist. What are the prerequisites for ovulation induction? When she comes on a day 2 on transvaginal ultrasound, I would like to see her endometrial thickness, which is less than 5 mm. Absence, if there is any absence of any active ovarian cyst, previous cycles, follicular cyst or corpus luteal cyst, and all the follicles should be less than 10 mm. Ovulation induction drugs are usually initiated between day 1 to day 5 because selection of dominant follicle occurs in early follicular phase, anytime between day 6 to day 8. So the most commonly used drug is CC because of its universally acceptable and inexpensive and safe on offspring. How to use it? As a traditional regimen, we start with 50 milligrams for from day 2 to day 5 for 5 days. And the most effective dosage would be 100 to 150 milligrams per day. And there is no difference if we start on day 1, 2, 3, or 4, 4 or 5. What is the success rate? The ovulation rate accounts up to 70 to 80%, pregnancy rate 30 to 40%, live birth rate 29%, cycle fecundity 15%, cumulative pregnancy rate is around 60% after 6 cycles. So when do we stop CC? If there is any resistance or failure. What do I mean by resistance? When she fails to ovulate even after receiving highest 150 milligrams dosage, and failure is defined as failure to conceive even after 6 ovulatory cycles of CC. So in the previous slide, I said the ovulation rate comes up to 70 to 80%, but the pregnancy rate is around 20 to 40%. That is because it's anti-estrogenic effect on endometrium, like anti-estrogenic effect on endometrium and cervical mucus. And other adverse effect includes multiple pregnancy, OHSS, hot flushes, nausea. So when the traditional CC regimen fails, so what is the next mode of management? First, as I already said, weight loss, a personalized, customized, realistic diet plan has to be given to all our patients so that she can target to reduce 2 to 3 kgs per month. So these are the other protocols which can be used before we step up into gonadotropins, which includes extended use of CC, stair-step CC, and these are the adjuvants which can be used. I want to mention here that we have n number of adjuvants in our fertility basket, but there are no big randomized control trials or meta-analysis saying the importance of all these adjuvants. But there are good studies on glucocorticoids, insulin sensitizers, L-carnitine, NAC, pre-treatment with OCPs, gonadotropins, and laparoscopic ovarian filling. So whenever the short courses of therapy fail, this study said an 8-day high dose, 8 to 10-day high dose treatment, that is 100 milligrams for 10 days, starting on day 3, would result in better ovulation rate whenever a short courses of therapy fail. Novel clomiphene stair-step protocol is that a protocol where we start 50 milligrams for 5 days from day 2 to day 6. On day 11 or day 14, we call up a scan. If there are no response, I say when I say no response, there is no development of dominant follicle that is more than 14 mm. Step up your CC to 100 milligrams for 5 days, call up a scan after a week. Even if there is no response, step up to 150 milligrams. So this protocol, in fact, it reduces the time to ovulation and improved ovulation rate. And we do not want to wait for another cycle to start a fresh CC cycle. Adjuvants. Clomiphene and glucocorticoids is most beneficial in cases of hyperandrogenic thin PCOS, where it's there is a synergistic action of FSH and improved follicle sensitivity to FSH. Clomiphene and metformin most beneficial in case of obese PCOS where there is hyperinsulinemia, insulin resistant. So evidence-based guidelines 2018 has told that clomiphene, when it is coupled with metformin, has better ovulation rate and clinical pregnancy rate. Preliminary suppressive therapy with OCP is most beneficial in cases where there are in patients where they are very highly resistant PCOD, there are high MH, altered FSH-LH ratio. So we treat her for 1 to 2 months with OCP, reduce her LH tone, and then start our ovulation induction. Clomiphene citrate can be added with L-carnitine and acetylcysteine. It shows to improve intra-ovarian factors. Coming to second drug, that is letrozole, which was discovered by Mitavelli and Casper. Letrozole is an aromatase inhibitor. It helps in monofollicular development. It has shorter half-life. There's no direct anti-estrogenic adverse effect like CC, and there is lower serum estradiol levels. This action of this can be used in OHSS. Evidence-based guidelines in PCOS in 2018 stated that letrozole should be the first line of management for all PCOD. Different regimens of letrozole is also there in the same way like how we use CC. Traditional regimen would be 2.5 milligrams daily for 5 days, reassess her on day 9 or day 10. And extended letrozole is giving 2.5 milligrams straight for 10 days, reassess on day 10 or day 11. Stair-step protocol, letrozole 2.5 mg letrozole, give her for 5 days. Do a scan 1 week after the last pill. If the follicle is less than 10 mm, increase the dose to 5 mg. And again do a USG 1 week later. If the follicle is less than 10 mm, increase the dose to 7.5 mg. And there is one more step up protocol. Give her on day 2, give her 2.5 mg. Day 3, 5 mg, day 4, 7.5 mg, day 5, 10 mg. So these are the protocol which uses the concept of FSH window and FSH threshold concentration to recruit more follicles and cost effective when we compare to gonadotropins, and the clinical pregnancy rate is comparable with compared to gonadotropins stimulation. Previously, there were a lot of speculation regarding congenital malformation, but this Sharma's clause study cleared the air. There is no, the congenital malformation is similar compared to natural conception, letrozole, and CC. Coming to gonadotropins, we have variety of preparations, urinary derived, highly purified, HMG, and recombinant FSH. So how to select a dose? It depends on the age, BMI, ovarian reserve, cause of infertility, and very important dose needed in the previous cycle. Does preparation affects outcomes? There were no difference in respect to clinical pregnancy or live birth rate compared to urinary, highly purified or recombinant. So the very important is to achieve to identify the FSH threshold dose that results in selection of single follicle. So the most commonly used protocol will be with oral ovulations for day 1 to day 5 and then color on day 7 for response. If there is no response, start gonadotropins as low as 37.5, 75, 150 depending on her body weight for 3 days and reassess until we develop a dominant follicle, and maximum dose can be given up to 225 IU. So this is a chronic low dose step-up protocol which can be used in a thin PCOS, especially in case where in previous cycles were cancer because of multiple follicle development. So we can start with chronic low dose step-up protocol, that is give 75 units FSH for 7 days, do a scan. If the follicle is less than 10 mm, increase it by 37.5 until there is a follicle of more than 10 mm. So step down protocol, it requires intense monitoring because we are giving higher dose of FSH. Start with 150 units IU for 5 days, and every 3 days we need to do ultrasonography. If the follicle is more than 10 mm, decrease by 37.5 IU, maintain the dose 75 units until HCG trigger. If the follicle is less than 10 mm, increase it by 37.5 units. Even with 225 IU maximum dose, if the follicle is more than 10, not more than 10 mm, we can cancel the cycle. So coming to laparoscopic ovarian drilling, it should be reserved for those patients who are very resistant, CC failed, letrozoled, and if she's a long-standing infertility requiring laparoscopic assessment of pelvis, and patient is who are not willing for intensive monitoring, so that patient is suitable for laparoscopic ovarian drilling. So in this, we use a rule of 4, using 40 watts at 4 to 6 spots per ovary at the depth of 4 mm for 2 to 3 seconds. Success rate accounts to 60% of ovulation rate, 55 to 65% of pregnancy rate, and the success is comparable to gonadotropins. What are the advantages? Spontaneous monoovulation, no risk of OHSS, and cost is almost equivalent to gonadotropins. The disadvantage would be if we overdo it, it might be we might land up with decreased ovarian reserve. So what are the practical points for ovulation induction monitoring? So when should be the first scan? When we start ovulation induction, let us do a scan on day 2 to confirm down regulation, that is endometrial thickness less than 5 mm. There's no follicles more than 10 mm. There is no active follicular cyst or a corpus luteal cyst. Field of the follicle can be decided by size, rate of growth, and vascularity. Changes in follicle that should be seen on a follicular monitoring scan. So the identification of dominant follicle more than 14 mm. After the follicle reaches 14 mm, it grows at a rate of 1.5 to 3 mm per day. Ovulation occurs at any time between 18 to 24 mm. There's increased perifollicular vascularity of dominant follicle seen on day 8. Endometrial changes, increases in thickness by 1 to 2 mm in proliferative phase. Endometrium starts becoming triple line from day 6 before LH surge and remains triple line till 7 days after LH surge. Trigger, in Letros or CC cycle, we can wait till 20 to 22 mm. Gonadotropin cycle, let us trigger when DF is 18 mm because of the scare of premature LH surge. HCG 5000 IU single ampule is more than necessary. Agonist trigger should be reserved only in cases when we are planning for IUI, when there are more than 4 follicles. That should be supplemented, provided it should be supplemented with intense luteal phase support. Rule of antagonist in IUI cycle, definitely it prevents premature LH surge, but adds up to the extra cost with no evident improvement in clinical pregnancy rate. Is it necessary to confirm ovulation? Yes, 1 cycle at least we have to confirm ovulation. Ultrasound signs of ovulation, the most important will be sudden reduction in size of dominant follicle, partial collapse of DF, and free fluid and POD. Startup LPD can be done day 3 or day 4 after trigger. That can be started. Vaginal or oral progesterone 200 milligrams BD for 15 days is sufficient. Take home message. Letros is the first line of the treatment for PCOS because we aim for single follicle. CC should be the first line for ovulatory cycles because in ovulatory cycle, dominant follicle, one single follicle is forming, but to improve the chances of pregnancy, we need to aim at 2 to 3 follicles. All ovulation induction has to be monitored for growth of follicle, endometrial growth, confirm ovulation. And good luteal phase support has to be given. Can use extended or step-up regimens of oral ovulation before starting gonadotropins. HCG trigger 5000 IU is more sufficient, and vaginal progesterone is enough for LTS. It's not what you give, and it's the way you give it. Thank you.
Thank you. Questions, ma'am?
Yeah, that was a very good presentation, Varshita. Very good.
Thank you, ma'am.
Dr. Padmarika, would you like to start the questions? Dr. Padmarika?
Yeah. See, what I wanted to ask is, Yes, very good presentation, very crisp and clear, and time was taken into consideration. What I would like to know is the topic is about ovulation induction recent trends.
Yes,
So,
ma'am.
should we distinguish between anovulatory women and ovulatory women? I have two questions. So this is the first question because lot of women who are ovulating also receive ovulation induction. By
Yes, ma'am.
definition, what you said is very correct that ovulation induction is to achieve monofollicular growth. But in reality, what is the evidence of giving ovulation inducing medications to women who are already ovulating?
Okay. Ma'am, first and foremost, I would like to emphasize on the duration of infertility and associated other factors, ma'am. It is not only ovulation or female factor is considered. So we also have to take if there's a long standing of infertility. So in such cases, if it is more than 2 years, 3 years of fertility, we need to give her ovulation induction. Ovulation induction in ovulatory cycle is not justifiable, ma'am, because we are already developing a single follicle. We are not doing any good. So in such cases, we need to target for ovarian stimulation to increase the chances of ovulation for developing 2 to 3 follicles, ma'am.
Okay. But when you look at, for example, the data which is published, there is still use of ovulation, oral ovulogens for ovulatory women, particularly, when they are undergoing IUI. So I think that has to be, when we are talking about ovulation induction, I would have, just briefly touching upon these issues. Because yes, in anovulatory women, yes, we need to go through ovulation induction, increasing doses, all that very beautifully narrated. But in reality, most of the clinics would be using in ovulatory women. So in what context it is right and where it should not be misused? I think just highlighting that would be very important. And the second thing is you were addressing about when we should be giving ovulation trigger. So is it mandatory or is it universally needed to give ovulation trigger for everybody who receives ovulation induction, or should it be a selective treatment?
Ma'am, it should be a selective choice because, of course, endogenous HCG is now there are studies because in IVF cycles we have moved on to natural cycle FET because our endogenous HCG is better improvement in endometrial receptivity expression. So in that way, if we think not all cases of ovulation induction requires HCG trigger, we can monitor for with LH monitoring kits, we can monitor for our natural search and give her every ovulation induction, if we are developing single follicle, again we don't need luteal phase support. If luteal phase support is required only if we are targeting more than one follicle.
Yeah, no, I was asking only about the ovulation trigger.
Ma'am, not necessarily all cases requires HCG trigger. Not universally should be used. It should be patient based criteria, ma'am. Select.
Ma'am, 3 minutes are
I
up,
think
ma'am.
I'll ask the other judges.
Yeah, shall we go to the next one, ma'am? 3 minutes are up, ma'am.
Since 3 minutes are over, we'll go to the next presentation.
Oh, thank you. Yeah. Dr. Deepthi?
Yes.
Thank you.
She's going to be speaking on IUI, IVF, ICSI, choosing the right intervention. Yeah, your slides have gone, Dr. Deepthi, again.
It's not seen, ma'am?
Yeah, it was seen so long. What did you do now? It's gone now.
Oh, okay. 1 second.
You want me to share for you?
1 second, ma'am. Share screen.
Yeah. Share screen, you keep on the screen.
Yeah,
Screen.
I think it's come back. No, ma'am?
Yeah, let's come back. Put it on slideshow and you can start.
Yes. Good evening, everyone.
Can you put it on slideshow? Sorry, can you put it on slideshow? The niche bottom, or go up to the top, slideshow. Click on slideshow.
I made a slideshow.
Is it okay? Ma'am, can she start, ma'am, like this only?
Not waste time, Simiti. Just start.
Yeah.
Can I start, ma'am?
Please.
Yeah. Good evening, everyone. So today I will be talking about IUI, IVF, ICSI, choosing the right intervention. So I'll be taking you through some case scenarios. The first one being a 27-year-old Mrs. A married to 33-year-old
Slides are not
Mr.
moving,
S.
Dr. Deepthi. Slides are not moving.
It's not moving.
Okay, married for, sorry?
Slides are, yeah, now it's moving. You have to click on each slide. Yeah, go on.
Yeah. 27-year-old Mrs. A married to 33-year-old Mr. S for 5 years, primary infertility. The female evaluation is within normal limits. The husband's analysis shows a count of 5 million, total motility 25%, rapidly progressive 9%, and normal forms are 3%. So it is oligoacidoteratozoospermia. So is IUI justified in this case? Yes, IUI is justified in this case. So when we come to the male factor, when the total count is 5 million and above, IUI is done. If it is 1 to 5 million, IVF is done, and less than 1 million, ICSI is indicated. Rapidly progressive is 10 to 20%, IUI is indicated. If it is 0%, rapidly progressive 0, ICSI is the treatment. When the normal forms are less than 1%, again, ICSI is the treatment. In case of azoospermia, in case of sperms which are obtained by PISA, TISA, or MESA obtained sperms, ICSI is the treatment. Donor IUI can be done in case of azoospermia. So the next case scenario is Mrs. S, age 27 years, and Mr. P, age 30 years, married for 1.5 years. They come with primary infertility. Ultrasound done showed there's bilateral endometriotic cysts. In the right ovary, the endometriotic cyst was 8 into 10 centimeters, and in the left ovary, the endometriotic cysts were 3.7 into 3.6 and 2 into 2 centimeters. And male parameters were normal. Thyroid was 3.05 since there was subclinical hypothyroidism. Any PSH more than 2.5 has to be treated in infertility. AMH was 5.6. So she was posted for operative laparoscopy, where we did right ovarian multilobulated endometriotic cyst was being removed. Cystectomy was done. There was adhesions present, adhesiolysis was done, and the left ovarian endometriotic cyst was again drained, and the cystectomy was done. On chromoperturbation, the right tube was blocked and the left tube was normal. So this is a case of endometriosis. So in endometriosis, minimal to mild endometriosis, IUI is the option. Moderate IVF, in severe ICSI is the treatment. And in case of tubal block, when there is one tubal block, IUI can be done, whereas in bilateral tubal block, IVF ICSI is the treatment of choice. The next case scenario is Mrs. X, age 36 years, married for 12 years, had 4 abortions. The first one was a natural conception. An MTP was done at 6 weeks. That was 10 years back. Second one was a TI conception, a missed abortion at 9 weeks. Third pregnancy was IUI conception, missed abortion at 8 weeks. And fourth one was an IUI conception, 9 weeks missed abortion, where products of conception was sent for karyotyping, and it showed there was trisomy 13. So it was a case of aneuploidy. So the male factor was normal in this case. So the key points in this case is secondary infertility, recurrent abortion, and aneuploidy. So in case where pre-implantation genetic testing is required, ICSI is the treatment, is the choice which we have to take. The next case scenario is Mrs. S, age 30 years, and Mr. K, age 33 years, married for 4 years, comes with irregular cycles with PCOS, and male parameters are normal. An ultrasound done showed there was intramural fibroid 4 into 4 centimeters in the posterior fundal region, and there was bilateral PCOS. AMH was on the higher side, it was 12.03, and hypothyroidism was present. HSC showed there's patent tubes. She underwent 6 cycles of TI and 1 cycle of IUI. Then she was being posted for operative laparoscopic myomectomy with laparoscopic ovarian drilling was done, and following which she had 1 IUI cycle. So in this case, I would opt for IVF ICSI. In case of PCOS, when there is irregular cycles and there's mild PCOS and AMH is less than 7, IUI would have been suggested. In case of irregular cycles, moderate PCOS and AMH more than 7, IVF. And in case there's when the AMH is more than 10, we consider it as resistant PCOS. There's high risk of OHSS. So, and they'll have usually irregular cycles, and they'll have only withdrawal bleeding. So in that cases, ICSI would be a best option. The next case scenario is Mr. X, age 30 years, and Mr. B, age 35 years, married for 8 years. Both male and female investigations are within normal limits. They've had multiple OITI cycles and even one cycle of IUI. So this is a case of unexplained infertility. So in case of unexplained infertility, based on the duration of infertility, we can decide the treatment option. So if it is less than 3 years, IUI would be the option. 3 to 5 years, IVF, and ICSI is the treatment if it is more than 5 years. The last case scenario is 33-year-old Mrs. R married to 36-year-old Mr. T. For 8 years, they have undergone 2 cycles of IUI and 1 cycle of conventional IVF. So in the conventional IVF, they got 13 oocytes. 6 in IVF was done. 6 fertilized, cleaved, and 3 day 3 embryos were formed. And FET was done, and it failed. So they came to us and they wanted to know what next. First, we did the male factor. We did a DFI, and the DNA fragmentation index was on the higher side. So in case of this patient, I would ask for ICSI in the next cycle. So this is because of previous fertilization failure or poor fertilization in the conventional IVF, and because of the male factor, which shows an increased DFI. So IUI, IVF, ICSI is still a dilemma. So the treatment option, the deciding factors will be the female age, the ovarian reserve, that is the AMH, and the antral follicle count, the tubal status, the comorbid factors like obesity, diabetes, and any other associated factors, the previous treatment, and the male factor. So when it comes to age, definitely the younger age group has a better prognosis compared to the older age group. In this picture, a 26-year-old with the AMH of 0.8 and AFC 7 has a better prognosis compared to a 37-year-old with AMH 1.4 and AFC 8. So when we come to the therapy proposal, age less than age above 35, and if one of the tubes are it's not patent, and the semen, there's oligoacidoteratospermia and 3 to 5 years of married life, infertility, then IUI would be opted. In case of bilateral tubal block and severe semen parameters more than 5 years, IVF ICSI is the option. So summarizing, IUI indications will be unexplained infertility, male factor infertility, cervical factor, mild endometriosis, ejaculatory failure like hypospadiasis, or neurological like spinal cord injury, psychological impotence, or zero discordant couple. When to refer for IVF? We have to refer to IVF when there's a woman with tubal disease, there's low ovarian reserve, there's severe oligospermia, and azoospermia in case PISA, TISA, or MESA obtained sperms are used. There's failed IUI, 3 to 4 cycles of failed IUI, failed other treatments in PCOS and endometriosis, unexplained infertility, when pre-implantation genetic testing is required, fertility preservation in case of cancer patients, egg donation programs required in case of premature ovarian failure or in case of low ovarian reserve patients, and surrogacy, that is third-party reproduction. In these cases, IVF ICSI is the treatment of choice. And ICSI indications will be severe male factor infertility, like alteration in the sperm characteristics, that is severe teratozoospermia, or the count is less than 5 million, surgically retrieved sperms, that is testicular epididymal sperms, previous fertilization failure or poor fertilization in conventional IVF when there are very few oocytes and there's advanced maternal age. The other indications will be when there are frozen thawed oocytes. Fertilization has to be done because denudation of the oocytes and freezing will alter the zona pellucida, and oocytes with abnormally thick zona pellucida in unexplained infertility when pre-implantation genetic testing is required in case of IVM oocytes and HIV discordant couples. In third-party reproduction, when donor eggs are used, IVF or ICSI both can be used. The donor eggs are usually used in case of premature ovarian failure, gonadal dysgenesis, repetitive IVF failures, inheritable disorders, and if they have attained menopause. And in case of donor sperms, a donor IUI can be done, and even IVF can be done. In case of azoospermia, donor IUI can be done, and if there is PISA, TISA retrieved sperms, ICSI is the treatment of choice. In case of oligoacidoteratospermia, in case of inheritable disease, In surrogacy, again, IVF and IVF-ICSI is the treatment of choice. So management of ART, one size doesn't fit all. We have to individualize the treatment customize the treatment based upon their age, their AMH, that is the ovarian reserve, their AFC, their male factors, the semen analysis, then their comorbid factors and previous treatment. And thank you.
Again,
Thank you, Aditi. Questions, ma'am?
Sundar, can you ask a question, please?
Yeah, wonderful presentation. Yeah, really, you made it very simple for everybody to understand it. I just wanted to know your case 3 and another 2 cases where the semen analysis was normal. You preferred ICSI rather than IVF. What was the special? I think case 3 and then subsequent.
Case 3, ma'am.
Case 3, you said that ICSI has been done, where I thought IVF also could have been done, no? Usually you do.
Ma'am, this was a case of aneuploidy because the products of consumption showed trisomy 13. So when pre-implantation genetic screening is required, testing is required, I think
IVF also
it's a
can be
better
done
option
for
because you can do a blastomere biopsy and a trophectoderm biopsy, which ICSI is a better option, ma'am.
Okay, that's why you have done ICSI in this case. Suppose I have a patient who has got a 45 years. Yesterday only I had one patient. She's
Yes,
45. She says, I'm very fit and regularly menstruating, but she's planning for a marriage now. And
Yes,
she
ma'am.
wants to go for the ART only. And
Yes,
which is the husband's analysis has been done, it's normal. She wants to go because of her age, she wants to go for a ART. Which procedure you would recommend for her? She's very in a hurry to conceive.
Yes, ma'am. I would recommend for IVF ICSI only, ma'am, because she's because of the advanced maternal age. So ICSI will be a better option, and she'll have. I mean, her reserve also will be on a lower side. When there are fewer oocytes, ICSI is a better option, ma'am.
When
Compared
you
to
have a between ICSI and IVF, if you do the analysis, I mean, not for having a male factor, I mean, not asthenospermia, zoospermia, what is the result success rate in the IVF and ICSI? Have you analyzed that so that you could say ICSI score over in these cases? Because here semen analysis is normal, only her age is the main factor. She is ovulating also, but she wanted IVF. Now, which is the, I mean, you have an analysis between ICSI and the IVF in such cases. I mean, apart from abnormal semen, their ICSI is, yes, universally.
Yes, yes, ma'am.
Have you
Because
got
in her
results?
case, ma'am, because she has fewer oocytes, I would opt for ICSI. Otherwise, when you take IVF and ICSI as such, the results are almost the same, ma'am. When you talk to the embryologist, they prefer IVF because there's naturally selected sperms. So they say the quality of the embryos will be equal even in IVF. Actually, it will be better in IVF is what they say because it is naturally selected sperms. But as you told, in case of male factor, ICSI is the option.
Yeah,
and in her case, because she has fewer oocytes, I think whenever there's fewer oocytes, there's advanced maternal age and all, I think ICSI is a better option, ma'am.
That means to say ICSI has got a more result, I mean, a success rate is more in ICSI than in IVF in such cases, you mean to say, is that?
Yes, ma'am. Yes, ma'am.
Okay, thank you. Good, well done, ma'am.
Coming to the same topic, what are the results of non-male indications of ICSI? Because we know that for the male factor, when you do ICSI, the results are good. But for non-male factors, what are the results of ICSI?
Yeah, that's what I asked, Jyotika. ICSI and IVF between.
Not as good as male factor. I think Dr. Padma can
clarify that.
clarify on it, Dr.
Dr.
Padma.
Padma?
Yeah. So I think the large, I mean, if we are looking at whether one is better than the other, whether IVF is better than the other, I think, or I mean, ICSI and vice versa, ICSI definitely only in proven male factor infertility, definitely yes. But otherwise, the large databases, countries like UK, France, USA have their national databases, and going through these databases, there is absolutely no difference in the success rate between IVF and ICSI for non-male factor indications.
Okay.
The only in real life, what happens is, especially in Indian clinics, it is largely private clinics, and all of us deal with a large number of poor responders. So when we have either very, like women who are older or women who are poor responders, then there is a fear of total fertilization failure. And especially in older women, maybe because of thickened zona, again, like IVF on its own may lead to a higher incidence of complete failure of fertilization. So, but this is not backed by available evidence, because we hardly publish from our country this data. So I think by and large, in non-male factor conditions, IVF and ICSI are both equally effective. As far as live birth rate is concerned,
Yeah, live birth rate.
surrogate markers like fertilization rate, cleavage rate, and number of embryos may vary between the two, but ultimate success is live birth rate, and then there is no difference.
Thank you.
Yes.
Thank you.
Thank you.
We'll go to the next one, ma'am. Thank you, Dr. Deepthi.
Thank you, ma'am.
Dr. Bhavya on fibroids and endometriosis. Yeah. Dr. Bhavya, yeah,
Yes, ma'am.
you can start.
Good evening. Thank you, KSOGA, for giving me this opportunity. For the next 12 minutes, I'll be talking on role of medical management in infertility in patients with fibroids and endometriosis. Sorry.
Yeah.
So, coming to the prevalence, fibroids are diagnosed in approximately 5 to 10% of women with infertility and are estimated to be solely responsible for infertility in 2 to 3% of patients. Because of current trend for women to postpone childbearing and fibroids occur more frequently in later reproductive years, these demographic trends will result in higher incidence of fibroids in women attempting to conceive. So, is there an association between fibroids and infertility? Yes. As we all know, according to the FIGO classification, depending on the location and the size of the fibroids, the submucosal and intramural fibroids that distort endometrial cavity result in lower pregnancy and implantation rate, whereas the subserosal fibroids do not seem to affect infertility. How about the intramural fibroids, which are not distorting the cavity then? So, the debate remains unresolved and it is difficult to reach a consensus because some data support the notion that larger leiomyomas more than 3 cm negatively impact reproduction, while other studies suggest that leiomyomas less than 5 cm do not. Why there is so much confusion even after so many years they are not able to reach a consensus is because the study designs are heterogeneous, there is inconsistent nomenclature, it is a continuous nature of leiomyoma, the size and location and insufficient patient recruitment. All this significantly limit the interpretation of results from existing studies. Also, the diversity of the leiomyoma. Not all myomas are the same and not all patients will have the same type of fibroid and also the same number of fibroids. This also limits the ability to determine whether leiomyoma size and location impact reproductive outcomes. So from this slide, what I would like to emphasize is that the uterine fibroids related infertility is not only because of uterine cavity distortion, but it also affects the endometrial and myometrial blood supply, and it also causes molecular changes such as decrease in the NK cells and increased interleukin 10 and also reduced expression of HOXA10. With all this, it will affect the implantation window and decrease the destrualization of the endometrium and hence lower implantation rates. So same thing is represented pictorially here. Then how can we manage the myoma related infertility? So the real question is there a place for medical management, especially when fertility preservation is the goal? Yes. The thing is, if the negative effect is related to the size of the myoma and its proximity to the uterine cavity, why should we not try a medical approach to reduce its size and push it back deeper into the myometrium, what we have termed the migration effect? So here we are. The new perspectives regarding the medical therapy for myomas is it is not only to treat symptoms but also to postpone or avoid surgery, to prevent recurrence after surgery in women at high risk, and also to prevent occurrence in women genetically predisposed to develop myomas. So here are the list of various medical therapies for intramural myomas. So estrogen, tranexamic acid, LNG-IUs are not so important for us because they do not reduce the fibroid size. They only improve the symptoms. For us, what is important is the medications which also reduce the fibroid size along with improvement in the symptoms. These are the selective progesterone receptor modulators, the mifepristone, GnRH agonist, and the GnRH antagonist. So GnRH agonist, they act on the GnRH receptor and produce a hypogonadotropic state and result in reduced estrogen and progesterone, and thus they shrink the fibroids. And selective progesterone receptor modulators such as the ulipristol, it causes apoptosis of the fibroid cells. So medical therapy, it complements the surgical therapy and it helps to reduce the size of fibroids, to control bleeding, to improve blood hemoglobin levels, to make surgery easier as a post-operative adjunct, to relieve signs and symptoms, and to prevent recurrence of fibroids after uterine conservating procedures. So this is from the FOXY guidelines. Ulipristol acetate can be used in a dose of 5 mg for about 3 months. It can also be used for 4 consecutive courses, and they recommend to do a baseline liver function test before starting ulipristol. And GnRH analogs can be used prior to hysteroscopic myomectomy, and it corrects preoperative anemia and also reduced blood loss. But it is not recommended before conventional and laparoscopic myomectomy due to possible loss of planes. And because of its side effects, it can be used only for about 3 to 6 months. So liver injury and ulipristol acetate, is it an overstated tragedy? Yes. This is because one could postulate that this is a very rare idiosyncratic event of drug-induced liver injury, and there is no doubt that excluding patients with liver anomalies or disorders at screening and checking liver enzymes during treatment courses will minimize the risk further. I would even say that even myomectomy is not free of complications, and the presence of myometrial scarring often requires cesarean section when giving birth. Mifepristone has an added advantage of oral administration, minimal side effect, less expensive, 80 to 85% success rate, and it also is used for acute abnormal uterine bleeding, and it's the drug of choice for infertility and type 3 myomas. So it can be used in a dose of 25 mg for 3 months followed by USG evaluation, and we can use keep it at a maintenance dose of 10 mg for additional 6 months. The advantage of mifepristone and ulipristol over GnRH agonist is that the fibroid will not regrow immediately after stoppage of these drugs. That effect will be maintained for about 6 months. 3 oral GnRH antagonists, linzagolix, elagolix, and relugolix, are shown to have rapid impact on heavy menstrual bleeding in more than 70%. When used without the add-back therapy, these drugs cause a significant reduction in fibroid volume, about 50% from baseline to week 24. When used without add-back therapy, it's only 10 to 15% reduction in the fibroid volume. The third generation agents such as aromatase inhibitors, letrozole and anastrozole, have also been studied for the treatment of symptomatic uterine fibroids, but it is being used off-label. So I would like to conclude regarding the fibroids by saying it is essential to personalize the medico-surgical strategy and propose a tailored approach on the basis of the main symptoms, which is heavy menstrual bleeding and infertility, which is what patients really want. Depending on the response to medical therapy, remaining myoma size and patient age, women can be guided toward natural conception or IVF if required, or surgical therapy. Next, coming to the consensus on infertility in endometriosis, the exact prevalence is unknown. 2 to 10% within the general female population is affected, and it is about 50% in infertile women. Endometriosis has been shown to induce infertility through a variety of mechanisms, and the reduction of ovarian reserve is one of the factors most directly involved in decreased fertility. So, in infertile women with endometriosis, clinicians should not prescribe ovarian suppression treatment to improve fertility. This is based on the results of the Cochrane review. Suppression of ovarian function to improve fertility in women with endometriosis is not effective and should not be offered for this indication alone. So, women seeking with pregnancy should not be prescribed post-operative hormone suppression with the sole purpose to enhance future pregnancy rate. But it can be given to improve the immediate outcome of the surgery for plain if she is not planning to conceive immediately. In infertile women with endometriosis, clinicians should not prescribe pentoxifylline and other anti-inflammatory drugs or letrozole outside ovulation induction to improve natural pregnancy rates. Then, is there a role of these medical therapies as an adjunct to medically assisted reproduction for endometriosis associated infertility? The extended administration of GnRH agonist prior to ERT treatment to improve live birth rate in infertile women with endometriosis is not recommended as the benefit is uncertain. So the goal of drug therapy for endometriosis is to relieve pain symptoms and improve fertility. The commonly used drugs are NSAIDs, progestogens, combined oral contraceptives, GnRH agonist, antagonist, then selective progesterone receptor modulators and SERMs, and also aromatase inhibitors. These medical treatments are based primarily on methods that inhibit ovarian function. As a result, medications administered for this purpose usually provoke contraception or subfertility, and these medical treatments therefore are not helpful for treating endometriosis associated infertility with the goal of improving outcomes including live births. So, but medical treatment has a potential advantage over surgical treatment, that it avoids the surgical complications and avoidance of profound ovarian reserve decrease, and there is no delay in infertility treatment. But the potential disadvantages of medical symptom treatment are it results in persistence of symptoms of endometriosis, accelerated progression of the disease, cyst complications, difficulty of ovarian access during oocyte retrieval procedure, and also follicular fluid contamination during oocyte retrieval procedure, and recurrent PIDs. So these are just for the completion's sake. These are the new drugs, but they are still at the trial level. And here is management of special situations wherein endometriosis and adenomyosis are two entities that share common symptoms with uterine fibroids. Despite endometriosis and uterine fibroids both being estrogen-dependent diseases, they present completely different response to progesterone. Endometriosis is characterized by progesterone resistance, whereas uterine fibroids grow under the influence of progesterone. The dose is also important. Elagolix is one drug which can be used in both, but elagolix is not effective at reducing fibroid size at the dose recommended for endometriosis, but it works at higher doses. These are my references. Thank you.
Thank you, Dr. Bhavya.
Thank you. Dr. Padma, would you like to ask her any questions?
Just an observation where you are mentioning about medical versus surgical therapy for endometriosis. You mentioned that with medical therapy, there is no delay in achieving pregnancy because they don't need that recovery time. But most of the medical therapy actually, as you yourself said, works as contraception.
Yes, ma'am.
Yeah, so I think it is contradictory, paradoxical what you have put in the slide. But it was a very good review of the literature.
Yes, ma'am. Compared to surgery, just when compared to surgery only, there's no delay in infertility.
Yeah, but Bhavya, the thing is, when we give medical therapy, none of them are instantaneously effective, right?
Yes,
so it's done over a period of time.
Yes,
so to the patient, it really is not the right message to be conveyed, because medical therapy does delay occurrence of pregnancy.
Yes, ma'am.
I think it is very, very important that we judiciously use all the modalities based on the scenario, but not sort of get confused or confuse the person in front of us. So your presentation was excellent, but that was a point I wanted to highlight.
Thank you, Padma. Bhavya?
Yes, ma'am.
Surgery, would you like to try some progesterone which does not inhibit ovulation? There are studies on it. Dydrogesterone can be used. There are studies which say dydrogesterone can be used
Yes,
in
ma'am.
operative period after you've done a surgical the excision or a cystectomy. Okay. And dydrogesterone does not inhibit ovulation, so she can spontaneously conceive during the. Okay.
Okay, ma'am.
It's a good presentation.
Thank you.
When the patient is on elagolix, would you like to, do you think she can conceive?
Elagolix is basically for pain relief, ma'am.
Whatever.
But it's a GnRH antagonist.
You're giving it for endometriosis, you're giving it even for fibroids. Okay, you can give for both.
Yes, ma'am.
You can conceive when the patient is on elagolix.
No, ma'am. Because
That is where there's a little misunderstanding. You can conceive, but you should not conceive because we do not have any reports. That
yes.
is, the patient is on elagolix, we have to be very certain and tell the couple that they have to be on barrier contraception.
Mhm.
Okay, because we
Okay.
do not have any data on the teratogenic effects of elagolix.
Yes, ma'am.
As time, Dr. Sundari can ask.
Ma'am, 3 minutes are
It's
up.
okay.
I'm sorry, ma'am.
It's okay, it's okay.
Is it?
Yeah.
Thank you. Thank you, Dr. Bhavya.
Three of
Thank
you
you.
did very well. Excellent.
Thank you.
Dr. Sangeeta,
Yes, ma'am.
she's going to be speaking.
She's the only one who's not
on
an
ovarian aging. Yeah.
She's the only one who's not an IVF specialist. Right, Sangeeta?
Yes, ma'am.
I know. The other three are all IVF specialists.
I'm assistant professor at BRIMS Bidar.
Yeah, I saw the TV dear. Yes, ma'am.
Good evening, everyone.
Can you put it on the slideshow? Go slideshow from the beginning, Dr. Sangeeta. Go to this one, the first button. First button.
Yes.
Yeah, go to the first
पूरे
button.
स्टेट के पूरे लोग हैं
First button.
जूम में वेट है
Go,
वो
नीचे,
ऑफ रखी हूँ
नीचे.
मैं
The first one from beginning. Yeah, perfect. Thank you.
Good evening, everyone. Today's my topic is on ovarian aging, the cause for concern today. So, from last 150 years, the life expectancy for the human beings has greatly increased from 45 to 85 years, but the age for the menopause remains the same, 50 years. And the ovarian reserve is essential for our fertility and also influences healthy aging in women. And in females, ovary is the first organ that ages more quickly than the other tissues. So in addition to the reproductive function, ovary also plays an important role in maintaining female hormone secretion. So why is it a concern today, ovarian aging? Ovarian reserve decreases with increasing chronological age, and it is also non-renewable. And women nowadays are choosing delayed childbearing, and which is resulting in more frequent use of assisted reproduction technologies. And they're opting for cryogenic storage of oocytes. These procedures are costly, and also the chance of achieving pregnancy is less with increasing age. And also the fecundity in both natural as well as a simulated ovarian cycle reduces with the maternal age. And most important key factor in ovarian aging is the oxidative stress, which is the important mechanism in causes like cigarette smoking, superovulation, and aging. All these factors, the mechanism is oxidative stress. So ovarian aging is a natural and the physiological aging process where we have loss of quantity as well as quality of the oocyte. The two major categories includes physiological as well as pathological. In physiological ovarian aging, it refers to the process by which the ovarian function deteriorates naturally with age until menopause. And in pathological overaging, it refers to the premature decline of the ovarian function, including the diminished ovarian reserve, premature ovarian insufficiency, and poor ovarian response in the field of IVF and ET. As we all know, the ovary has both reproductive and endocrine functions. Ovarian reproductive function is mainly controlled by the HPO axis during the regular menstrual cycles, and the endocrine functions is mainly the secretion of steroid hormones and a small amount of androgen, various cytokines, which help in the development of the reproductive organs. And the main clinical symptoms of ovarian aging, this phenomenon of aging leads to infertility, abortion, birth defects due to poor oocyte quality, and menstrual cycle disorders like oligomenorrhea and even amenorrhea. And the systemic deterioration also caused by the estrogen deficiency, which acts on the estrogen receptors on the other systems like cardiovascular system, musculoskeletal system, and immune system, and also has disturbance in the emotional and sleep patterns. And how do we test for this ovarian aging is by the ovarian reserve tests. Ovarian reserve test mainly involves the anti-Mullerian hormone. AMH. This is the dimeric glycoprotein and it is expressed by the granulosa cells, by the antral and the preantral follicles. And decrease in the AMH, it is the sign of exhaustion of the total follicular pool, and it is almost undetectable by menopause, and it is the better marker than the AFC and the basal follicle stimulating hormone test. Next is the antral follicular count, and it provides the direct ovarian assessment by transvaginal ultrasonography. Here we normally about 10 to 20 is considered to be normal, and less than 10 are the poor responders. Then we'll come to the basal follicle stimulating hormone, basal estrol, inhibin B. These are also used in the used as ovarian reserve test, but not much recommended. And some studies also take ovarian biopsy and genetic markers for the ovarian reserves have a minimal value in predicting the ovarian reserve. What is the potential mechanism of ovarian? Ovarian aging mainly involves the decrease in the oocyte quantity. As we know, women are born with a limited number of oocytes, and this graph shows the how the oocyte quantity decreases. Around 16 to 20 weeks of gestation, we have around 6 to 7 million primordial germ cells, which decreases to approximately 1 million at birth. So by the time we reach the menarche or puberty, we are left with only 3 lakh primordial follicles, and on an average, only 350 are ovulated during the reproductive age, and all other will get atretic, and around menopause, only 1,000 are remain. So the lifespan of the ovary depends on the balance between the survival and the death of the oocytes. However, the damage during this ovarian folliculogenesis, including the activation, recruitment, and development of early follicles, it has a complex relationship with ovarian aging. The depletion of the primordial follicle pool is caused by massive follicular atresia, and periodic ovulation is the fundamental cause of ovarian aging. The other theory for decrease in the quantity is the dispute over the germline stem cells in female mammals. Traditionally, it is believed that germline stem cells have been thought to not to exist in female mammals. A published result by Hennot and Clark support that the germline stem cells do not exist postnatally in the female mammals. And this concept is consistent with the fact that the continuously depleted non-renewable ovarian reserve with age is the key limiting factor in ovarian aging. So how the oocyte quality is decreased? It is mainly because of chromosal cohesion deterioration, telomere shortening, DNA damage response associated with genetic mutations, and reactive oxygen species and oxidative stress, mitochondrial dysfunction, epigenetic influences on the ovarian aging, and the ovarian microenvironment also affects the ovarian aging. And the factors related to oxidative stress that lead to ovarian aging are aging itself, cigarette smoking, high sugar diet, pressure, superovulation chemotherapy, and industrial pollution. What are the intervention strategies we use? To date, there are no clinically feasible techniques to either maintain or reverse ovarian dysfunction associated with this advanced age. Some of the important this efficacy of the antioxidants on the reproductive aging are the resveratrol and nicotinamide mononucleotide, melatonin, and coenzyme Q. They prevent oxidative damage as well as delay ovarian aging. This resveratrol is a polyphenolic compound. It is found in the red grapes. It has antioxidant, anti-inflammatory, cardioprotective, and anti-neoplastic properties. It improves the mitochondrial function and protects against the metabolic disease, and also enhances maturation and quality of the aged oocytes. But this doesn't have, it has adverse effects on implantation and endometrial deserialization. So effect of resveratrol are time and dose dependent. Next, melatonin is an endogenous hormone, and it is primarily released by the pineal gland to modulate many important physiological reactions. Melatonin and its metabolites effectively decrease the oxidative stress levels by directly scavenging the reactive oxygen species as well as enhancing the antioxidant activity, and helps in the modulation of the mitochondrial and inflammatory activities. Mitochondrial therapy. Aged oocytes have significantly reduced amounts of mitochondria, leading to lower fertilization rates and poor embryonic development. These mitochondrial nutrient therapy and mitochondrial transfer therapy are the two important approach to combat the stress. This is done by coenzyme Q10 is an essential component for transporting the electrons in the mitochondrial respiratory chain to produce the cellular energy. Ubiquinol, it is a reduced form of coenzyme Q10, acts as an antioxidant in the cellular metabolism via the inhibition of lipid peroxidation, protein and DNA oxidation. So supplementation with CoQ10, it helps in delayed depletion of ovarian reserve. It restores oocyte mitochondrial gene expression and also improved mitochondrial activity. But coenzyme Q10 has the effect especially on age-associated mitochondrial dysfunction, but does not have any effect on young oocyte with good mitochondrial function. And fertility preservation by ovarian rejuvenated from pluripotent stem cells. Primordial germ cells, it give rise to both oocytes and spermatozoa. Primordial germ cell-like cells, they have been successfully induced from the pluripotent stem cells. Functional oocytes can be developed in the recipients following the transplantation of these PGs aggregated with fetal somatic pregranulosa cells into the kidney capsule, ovarian bursa, and intra-ovarian injection. This effectively restores folliculogenesis as well as endocrine functions. So the majority of the PGCs enter meiosis and undergo folliculogenesis, but they disappear about 6 weeks following transplantation. To prevent this, germ-like competent pluripotent stem cells are developed by purely chemical approach from the granulosa cells. So, though oocyte and germ cells are not absolutely required for living, but reproduction is critically important for the survival of the population of the living species, and a healthy baby should be a nice heritage for the families. So it is suggested for the female to deliver the babies before 30 years because of the possible ovarian aging, and women delaying childbearing aging should think of cryopreservation of the oocytes, and antioxidant therapy has been initially proved to improve the quality of the oocyte in vitro, but further studies are needed to determine whether it can improve the pregnancy outcomes in patients undergoing ART. Thank you.
Thank you, dear. Thank you, Sangeeta. Dr. Sundari, can you ask her?
Yeah, it's an elaborate this one on ovarian failure, aging of the ovarian, lot of drugs you said. Is there any evidence that all these things are being tried and helpful for preventing the ovarian aging, like your melatonin and resveratrol, all these things you said, no? Is there any evidence now for that? You didn't quote the,
Yes, ma'am, I didn't quote the evidence, but there are evidences showing that melatonin, coenzyme Q10 can help, but further studies are still needed to
it is
confirm.
only in the experimental stage. Now, what about PRP for ovarian aging patients who are infertile also? What do you think role of PRP, platelet-rich plasma for the ovarian aging?
It can be tried, ma'am.
Is it not? Is it tried? I think our rescue is Dr. Padma. She's there, no?
Yeah, Padma Rekha is there.
Padma? Yeah, I'm there. Yeah.
I think questions.
I think a lot of people are trying in the infertility clinics also PRP for ovarian aging and.
Yeah, PRP is used for ovarian rejuvenation.
Yes.
But it is still considered as an experimental procedure because high level of evidence is not available. Okay. Even the procedure, of preparation of active platelets is not standardized.
Okay.
So there are always, like small studies from individual groups which have shown some improvement. And we have to remember these are the women who would have otherwise gone for egg donation. So there is some clinical evidence at individual level. Yes, it works. But to offer it as a mainline therapy, that level of evidence
is lacking.
Dr. Padma, you can ask her a question too, Sangeeta.
I think other judges, if they wish to ask.
Are there.
Yeah. So I think, as you already said, it's an enormous topic, and the ramifications of reduced, declining ovarian reserve or the ovarian aging has multiple ramifications. So it was a good presentation, Dr. Sangeeta. So I just would like you to summarize what are all the ramifications of this declining ovarian reserve or ovarian aging? Do you believe in India it is a problem? Do you think that Indian women go through, as an ethnicity, an accelerated ovarian aging compared to Caucasian women?
Yes, ma'am. Ovarian aging nowadays, it has become a concern because many women are delaying childbearing. Aging increases as the age increases, and the ratio of the follicle also increases as the increases, and we are more prone for this oxidative stress. Nowadays, we are this stress, high sugar levels, and super ovulation. All these will increase the oxidative stress, which is the main key factor for the ovarian aging.
Sangeeta, what Dr. Padmarika is asking is, do we have ovarian aging in our country in even younger people? Not just older people, yes, you expect it. But do you see it more often now in younger people too?
Ma'am, we will stop, ma'am, because it's
fine.
3 minutes.
Yes, okay.
Thank you. Thank you. So that finishes our 4 speakers. So now we have a great pleasure in having our expert who's going to be speaking on fertility preservation, and no other than Dr. Padmarika Jirve, who's the president of Fertility Preservation Society of India. So it's indeed a great pleasure having you with us, ma'am, and I would ask you to start your talk, please. Thank you very much, ma'am.
Thank you. Thanks for having me here today. And let me just, can you see my slides?
No, ma'am, not yet, ma'am.
No? Just hold on. So fertility preservation, I mean, first of all, I think it's been an excellent activity. I've never come across this kind of activity being conducted by any of the organizations.
Ma'am, it is Sir's brainchild, ma'am. Sir's brainchild.
I must really...
It goes to Durga Das. The credit goes to Dr. Durga Das.
It's an amazing initiative, and I think this has to be commended and copied and followed by many of the other organizations. Can you see my slides now?
Yes, ma'am, but it is not full screen, ma'am.
Yeah, I'll do it. Yeah.
Yes, ma'am. Perfect, ma'am. Thank you, ma'am.
Yeah. So, fertility preservation, I just thought we'll go through a quick overview of what this stands for. Primarily, I think we all know that fertility preservation came into vogue as a means of achieving fertility in young, we say Kaya, that is childhood, adolescent, and young adult affected with cancers. And what we know is that 80% of the cancer survivors view themselves as potential parents. Vast majority see this cancer experience as pivotal in preparing them to be better parents. So this is a well proven, there's a huge amount of evidence about this when we assess the knowledge attitude practice surveys and look at what these young people, cancer survivors, feel. So on one side, they believe that once they are cured of the condition, they are going to be parents one day. And on the other side, survival of this Kaya cancer affected population has improved dramatically over the past 3 decades. And by and large, it is considered as somewhere around 80 to 85% in the population below 40 years of age. But what we know is that if we don't intervene at all with the natural course and let them go through cancer therapy and then later on try for pregnancy, what we know is that compared to their siblings, they have a significantly lower chance of achieving pregnancy. So this is a beautiful study where they looked at the childhood cancer survivor. This is a very well-known study cohort that is more, 11,000 survivors versus about 4,000 siblings followed up for 8 years. So compared to siblings, the chances of achieving pregnancies nearly 40 to 45% less. So this is a very important thing. If we don't intervene, a large majority of them would remain infertile. So if we look at men, again, the red line indicates the survivors, and the blue line the siblings. As we can see, there is a significantly less chance of achieving pregnancy in those who have been affected by cancer, and especially if they have received alkylating agents. Again, that has an additional impact on the chances of achieving pregnancy in future. Similar graph in female survivors as well. Compared to their siblings, they have a significantly lower chance of achieving pregnancy across all age groups. That whether they're young or older, the chances are low. So why does this happen? Why does cancer affect fertility? It is a four-prong effect. One is many of the malignancies themselves actually affect the chance of future fertility, compounded by the type of surgeries they undergo, the chemotherapy they receive, and the radiotherapy they may receive. And over and above all this, there is this factor of age. Age stands for age-related gamete exhaustion, especially in women. So that also, while they're going through cancer treatment, recovering from that, going through follow-up, they are obviously aging, and that is leading to a natural exhaustion of the gametes. So now let us see what is the impact of cancer on fertility, the disease in itself. It is very evident in those who undergo those who develop any of the gynecological malignancies, because the pelvis itself is affected. We can easily understand how it brings down their chances of a successful pregnancy in future. But non-gynecological malignancies also, especially breast cancer, one of the commonest cancers, particularly those with BRCA mutations, are known to have poor ovarian reserve. And any type of malignancy is found to be associated with low AMH and AFC, that is reduced ovarian reserve markers, that is malignancy, compared to infertile women without malignancy. Then lymphoma and leukemia, the additional challenge is malignant cells may be present in the ovaries, thus even offering fertility, certain types of fertility preservation techniques can be challenging in these women. What about malignancy in men? It is well documented that certain type of malignancies, particularly testicular cancer, myeloid leukemia, and lymphoid leukemia, they do experience, maybe because of their systemic effect, maybe because of the fever, maybe because of various other immunological mechanisms, they tend to have a lower sperm count even before any therapy is offered, compared to those who do not have any malignancy. So one of the important take-home messages in these types of malignancies in young boys and young men is that we may have to freeze more samples of semen before they go through any definitive treatment. One of the other findings has been is that those who have malignancies tend to have a increased sperm DNA fragmentation. So even if they have normal semen parameters, apparently normal semen parameters, these semen samples may not be functionally as good as those who do not have malignancies. Now, what about one of the modalities of treatment, that is surgery? So we know that when we do ovarian surgery for ovarian tumors, whether they are borderline or malignant tumors, even if we do conservative surgery, there is damage to the ovaries. Sometimes it is only cystectomy, sometimes it could be part of the ovary being excised. So there is a reduction in the primordial follicular pool, which will have its consequences in the long run, compounded by the vascular damage due to surgery. So conservative surgery for early cervical carcinoma, we know that it doesn't reduce the fertility, but it has certain obstetric implications in that preterm deliveries and incompetent cervix and loss of pregnancies is increased in this group of women. What about surgery and fertility in men? Many patients with testicular cancer experience anejaculation because they have a retroperitoneal lymph node dissection as part of the treatment. So this is something we must remember, that even though their sperm count is not affected, even though they actually have a good testicular function, anejaculation actually leads to inability to ejaculate and achieve pregnancy at a later date. What about chemotherapy and fertility? We know that there is a large group of chemotherapeutic agents which are very effective in curing the cancer, but they are gonadotoxic both in men and women. And the effect of chemotherapy is influenced by dose of chemotherapy, whether radiotherapy is being added to that, and type of chemotherapy, and of course, age of the individual. In women, as compared to younger women, older women with cancers, that is in their late 30s, are more likely to have a higher gonadotoxic effect compared to younger women, because already their ovarian reserve is reduced. So when we talk about gonadotoxicity of chemotherapeutic agents, many of them have absolutely no impact on the ovarian reserve in the short run. Some of them are considered to have moderate effect, such as various platinum-based therapies, and alkylating agents are the ones which are most toxic, gonadotoxic to the ovaries in young women. And what the mechanism is believed to be mainly affecting the growing follicular pool. So the primordial follicular pool may be protected. So that's why in older women who have already reduced primordial follicular pool, the effect is more exaggerated because there is very little of that to be recruited. Whereas in a younger woman, the growing pool, even if it is completely damaged, there is gradual improvement in the ovarian reserve, because the primordial follicular pool eventually leads to recruitment of further follicles and recovery of ovarian function. But what is important at this juncture to remember is, anybody who has regular menstruation doesn't mean that they have normal ovarian reserve. For decades, this is how the young girls were counseled, saying that, okay, if your menstrual function returns, you have a very good chance of achieving pregnancy, and that is not correct. So the toxicity can be direct ovarian toxicity, vascular toxicity, or cellular effects, or a combination of these. So this is the effect on the ovaries. What about in men? It is usually the germ cell component which is affected. The somatic component, the Leydig cell component, is more resistant because there is no mitotic activity going on there. So these men tend to have normal LH and testosterone concentration, whereas the germ cell compartment is affected. Hence the spermatogenesis is what is affected. And also the effect of chemotherapy additionally could be to induce certain genetic abnormalities in the sperms as well. So again, similar to what happens in women, it is alkylating agents which are most gonadotoxic, and the mechanism is direct damage to DNA and RNA and induction of apoptosis. 63% of adolescent boys treated with MVPP regime for Hodgkin's remain azoospermic at 10 years post treatment. Whereas, they tend to have normal LH. So their sexual function is not really affected. It is the reproductive axis which is affected. What about radiotherapy and fertility in women? Direct pelvic radiation has a high incidence of premature ovarian failure to the tune of 90%. With oophoropexy, like transposition of the ovaries in a higher up place, the risk is reduced, but it's very difficult to predict what is the risk, because the ovaries are known to migrate, and also the scattering effect of the radiotherapy is also there. So it is very difficult to predict how much of protection this can achieve. In addition, there are other aspects of radiation injury to the uterus. So even if the ovaries are protected, there could be infertility due to damage to the endometrium, or they may have recurrent miscarriages or preterm labor as well because of the physical reduction in the size of the uterus and the functional reduction as well. Also, the other aspect is even if they're not receiving any radiation to the pelvis, cranial radiation, which happens in those who receive stem cell transplantation, it leads to a damage to the hypothalamo-pituitary ovarian axis, both in prepubertal and postpubertal girls, and that indirectly can lead to infertility. What about radiotherapy in men? So there is huge array of damages that can happen from direct disruption of gametogenesis because of apoptosis and damage to the germinal cells, to vascular damage, to immunological damage, disruption of various paracrine events. And again, it is the combination of radiotherapy and chemotherapy act in an additive way. All this can lead to various damages, and hence we have to remember that usually the modalities of treatment can be more than one. So we need to take all these things, the direct effect of cancer itself, what is the type of chemotherapy, what is the type of radiotherapy, what is the dose of radiotherapy. All these things can have an effect. What about cancer therapy and conception, future conception? A treatment-free period is advised to minimize the risk of aneuploidy and teratogenicity, even if their gonadal function returns. Ideally, it is considered as 2 years after commencement of radiotherapy and 1 year after radiotherapy. No increase in the risk of genetic and congenital abnormalities are compared to children of survivors' siblings. These are coming from large national databases where cancer registries are available. Expediting fertility management is important as reproductive lifespan is reduced. So on one side, we need to wait patiently for the cancer specialist to give us a go-ahead to consider any fertility treatment, and also for the effect of chemotherapy and radiotherapy to get washed out of the system. And once that stage is achieved, if they have not done any fertility preservation previously, then expediting the management is important, because even those who might be having reasonably good ovarian reserve, it is in general noted that the ovarian, the reproductive lifespan is reduced, because even the molecules which are considered as less gonadotoxic or least gonadotoxic, when they are observed over a period of time, over 5 to 10 years, it is noticed that compared to those who have not received age-matched controls, who have not received any chemotherapy or radiotherapy, their ovarian reserve does come down. So there is some kind of reproductive lifespan reduction happening, even in those conventional chemotherapies which are not considered to be gonadotoxic, and this is something we need to bear in mind. What about subsequent fertility in men? Male survivors of childhood cancers, there is no increase in the incidence of genetic disease in their offspring despite chemo and radiotherapy. The US cohort study, the US and Danish studies are the largest to date. The US cohort study showed that no increase in the congenital malformations compared to, either through natural conceptions or ART conceptions in these cancer survivors. However, Danish study showed that there is a 17% increase in major congenital malformations in the offspring of male cancer survivors. These were not genetic abnormalities. These were just structural abnormalities. So there is some concern here. These are contradicting reports from two different national registries. What about those who undergo assisted reproductive technology, in those who have not done any fertility preservation and have previously treated for cancers? If we look at cancer versus no cancer, as we can see, there is a significant reduction in the chance of achieving pregnancy in these women. However, if they used donor oocytes, then obviously there is no difference in the two groups. So there is an overall reduction in the success rate. Hence, the role of fertility preservation, which is a truly multidisciplinary field, a complex scenario influenced by availability, acceptance, culture, and geography, financial implications, and the challenges involved in consenting of minors, and also the challenge of posthumous reproduction. So it is not a simple storage of gametes and then utilizing them later on. When they are going through this very sensitive period of cancer and thinking of survival, we need to discuss about reproduction and gently also bring in the actual legalities of how do we, like how much information is to be given to the minors, what is to be, how we take assent from them and how we consent the parents, and also how to bring in the issue of posthumous who has the, who is entitled to use the gametes if a person dies following preservation. So this has become a reality due to the fertility preservation has become a reality due to the advances in the field of reproductive medicine. But these complex issues will have to be borne in mind. There are multiple international guidelines which govern our practice of fertility preservation. They very categorically state when we should promote fertility preservation, which are the suitable procedures under various conditions, and how do we go about establishing these services. So we have gone through, these are the reasons why we need to think of fertility preservation. What is important is all these international organizations have now clearly stated that fertility preservation should be discussed right at the, like soon after the diagnosis. Whether it is recommended comes later. But there is an option of fertility preservation. Yes, it is indicated, but or it is not indicated because the therapy you go through would be very safe, or this field exists, but in your case, we cannot advocate this because of various risks associated with a particular malignancy. This is the discussion that needs to be carried out by oncologists. The majority of the countries now have a checklist in the oncology clinic in itself where they have to document and say whether we have discussed it and whether the patient has declined it. And so it is important to note that it is not an option we have at present, and it needs to be discussed. In addition to the malignant condition, there are certain non-oncological medical conditions where we may have to consider fertility preservation, even for benign conditions, particularly autoimmune diseases. And as I mentioned earlier, for sickle cell anemia, thalassemia, not necessarily for malignancy, but hematopoietic stem cell transplantation may be considered for certain benign conditions as well. And certain situations where we think that there is a high chance of premature ovarian insufficiency or primary ovarian insufficiency, particularly in those with Turner's and mosaic Turner's and Fragile X mental retardation, galactosemia, and beta thalassemia, then male genetic disorders, Klinefelter's, and of course, endometriosis in young women, gender reassignment procedures. So this is becoming more and more of a reality now. And then, so these are the situations where fertility preservation may be indicated even if the condition is benign. And the third thing is age-related gamete exhaustion, and age banking is another thing we have to consider, as has been discussed previously during the presentations. More and more women are choosing fertility at a later date, and if they are very clear about it, it is necessary that we have to bring in this discussion maybe in their early 30s and not when they are at 38, 39 years of age. Beyond that, what will be the procedure we may have to offer? There is a very good algorithm based on age, gender and age. So in prepubertal boys, it's very challenging because we do not have any idea. Testicular cryopreservation is the only option, and we do not have any clinical evidence as to testicular transplantation at a later date. What is the outcome? We do not know. But pubertal and post-pubertal, yes, the easiest way is to collect the semen and freeze. Sometimes it may require some vibratory stimulus. Sometimes one may need electroejaculation. And if there is azoospermia, again, testicular biopsy can be done, and small aliquots of sperms can be cryopreserved. But it is very important that these aspects are borne in mind, even in many of the peripubertal boys are capable of masturbating and giving the sample, and they may be not very comfortable discussing this in front of their parents. So that space needs to be provided, particularly for this young boys. For women, of course, the choices we have are ovarian stimulation and cryopreserving oocytes, which requires basically a period of ovarian stimulation over 10 to 12 days. And usually, if it is surgery followed by chemotherapy, it is in the transit between the two procedures when ovarian stimulation is carried out. And there are well-designed protocols for hormone-sensitive tumors as well, where we can actually prevent a high level of estradiol during ovarian stimulation. Where there is no risk of cancer cells being present in the ovary and ovarian stimulation is not possible, then we can consider cryopreservation of ovarian cortex, which involves a laparoscopic procedure to take part of the ovary and then cryopreservation. This is a challenging process. There is very limited expertise available within the country regarding this. And of course, future processes involve isolation of ogonial stem cells, artificial ovary, in vitro creation of follicles. So these are all very exciting, but at present, they are very experimental. So this is what I was just mentioning. Even those chemotherapeutic agents which are considered as safe and not gonadotoxic, there may be a shortening of reproductive window. So those women who have already received these medications and then come to us with some ovarian reserve, it is very important to have a proper reproductive counseling and encourage them to go through fertility preservation. If they're not considering actively pregnancy at a later date, then consider fertility preservation even after chemotherapy. So conclusions are cancer itself and all treatment modalities may affect future fertility in men and women. Hence, fertility preservation is indicated and is feasible in those with good prognosis for malignancies. It is a multidisciplinary management and that has to be respected and introduced right from the beginning of the management. It basically, fertility preservation extends and shifts the window of fertility to a more suitable and safer time period in their course of treatment. So coordination between oncological team and ART centers is very essential. Appropriate reproductive counseling is increasingly considered mandatory across globe. Thank you.
Much, ma'am. Jyotika ma'am, you want to?
Padmarika, that was a very good presentation, but I was hoping you would spend a little more time on how we do the fertility preservation.
I mean, the procedures?
Yes, the way different methods of fertility preservation,
The stimulation protocols?
Okay.
Yeah. So I mean, if you are...
Then, ovarian strips being preserved.
Okay. So I mean,
that's what.
No, probably she wants whether it's a oocyte preservation, embryo preservation, or ovarian tissue preservation. Probably.
Yeah.
Jyotika wants that, I think.
So if we are, I mean, whether it is oocyte cryopreservation or embryo cryopreservation, we will need to do ovarian stimulation. So what is important here is that we can do ovarian stimulation irrespective of the time of the cycle a patient comes to us. So that is how the random start protocols have come into vogue. So so that the time is not wasted. So by utilizing antagonists to cause like luteolysis, even in luteal phase, we can start the stimulation. And we can add letrozole or tamoxifen to keep the circulating estradiol levels at low level. Because we are not going to do embryo transfer in that cycle, we are not concerned about the effect of very low estradiol on the endometrium. So, but they will need about approximately 12 to 14 days for stimulation and egg collection. And whether we do oocyte cryopreservation or embryo cryopreservation depends on whether in our country, whether it's a married couple coming this treatment. Even in married couple, we if she responds well and we get good number of oocytes, in a gentle way, it is better to counsel them and to give them the reproductive autonomy. It is important to say that, like we can fertilize and freeze number of oocytes as embryos and some oocytes as oocytes, because in case there is a marital discord, she will have complete autonomy over her oocytes, whereas embryo, both of them will have to consent. So this is one important aspect. As far as ovarian cortex cryopreservation is concerned, actually, the procedure of taking a part of the ovary, any good laparoscopic surgeon can do that. So that is probably the least challenging part of the process. And also, when we do this ovarian cortex cryopreservation, as we tease the tissue and cut them into thin strips devoid of the stroma, literally 1 millimeter thick strips, there are some immature oocytes we can get, and that gives an opportunity to do IVM and in vitro maturation, freeze some of those oocytes as well. But the biggest challenge is the media that is required, the expertise to there is either we can do vitrification or we can do slow cryopreservation, slow freezing by slow freezing technique. But the practical issue is the culture media for vitrifying or for slow freezing of ovarian tissue is not easily available. It is very expensive, so that we can't, it's not easy to say, okay, we will keep a stock of this media continuously. But some of the clinics where we are doing this, we just have to take that hard decision and say we will, because we never know when that need arises. And once sort of the go ahead comes, once the malignancy is cleared, now they are saying that even for hemopoietic malignancies like leukemia, we can subject the tissue, frozen tissue, to certain testing, like they would do for tumor markers, and see whether there are any residual malignant cells in that. But if leaving that aside, where it is considered safe that there is no residual malignant cell, possibility of malignant cells in the tissue, the transplantation is most often the preferred site is getting them back into the into their natural space, that is the ovarian fossa. So and the advantage is that if we have adequate number of strips available, all of them need not be transplanted in one go, because it is known that they do undergo slightly faster exhaustion than normal. So getting them in their normal space also gives a chance for natural conception, and having good number of strips frozen, we can repeat the transplantation after a few years if the need arises. And they have the entire range of treatment available for them, whether it is natural conception, whether it is, and we do see that the FSH gradually starts going down 3 to 4 months after the transplant, and AMH takes a little longer to go up, but many of them do achieve pregnancy. I think there are more than 250 pregnancies achieved over, across the globe, mainly reported from Western Europe and the US.
Thank you, Padma. That was very nice. Thank you so much for agreeing to be with us today, to give your talk and to judge. Srimati?
Yes, ma'am. Thank you very much. Sir, anything you want to add before we conclude, sir?
I just wanted to add, I'm really sorry. I thought it's not a totally ART group, so I didn't go into the details of oocyte and cryopreservation, oocyte and ovarian.
See, Padmarekha, if it's an ART group, they know what, then they know about the non-ART group have to be told.
Yes, point well taken. Thank you.
I have one question for Dr. Padma, Dr. Shobha Guri here, Padma. Yeah. So I just see recently, I still ongoing patient with me who has recurrent serous cyst adenomas. Recurrent, however well we do the cystectomy, it keeps recurring.
So on the same side or bilateral? You're muted. Dr. Goody, you are muted.
Ruba, you're muted, huh? Okay.
So it is bilateral. And I have done both sides cystectomy. And now the thing is, her AMH is on the lower side. It is around 1.8 or 2 or something like that. And recently, when twice I have consulted Madhuri Patil on this, and once Mahesh Koregal also, they have suggested preservation, but simply the couple is not accepting it. They feel that, whatever it is, we will go for natural. Well, that is their take on the situation.
Yes.
My question to you is when there are recurrent disease in the ovary, which is benign, and this is what happens. What are the ways forward? Because she is again currently trying for pregnancy, but she is again having a almost 7 into 8 centimeters serous cystadenoma on the left side. The CA125 as always is normal, and this is the situation. On
Yeah.
imaging, the right ovary actually looks small. I don't know how conservative I have been, but even then it is looking small. Can you please guide me a little on this case? Yeah.
I mean, it is like I think you've given her the right guidance and they have been reluctant to take. See, I mean, for some reason, she seems to have this tendency to have recurring. So in this case, ideal thing would be to expedite fertility. Repeated surgeries, even though they are benign, repeated surgeries are going
That
to
itself can compromise. I agree with you.
So, sort of, like trying to preserve cortex, I mean, freeze cortex in this situation is worrying because we do not know whether she has a tendency to eventually develop borderline
Exactly.
tumor.
Yeah.
So the only safe option for her is to go ahead with IVF and, like preserve as many, I mean, take a chance with IVF. Depending on her response, if she responds well, if she's young and directly she can go ahead with embryo transfer. But if for some reason they want to delay pregnancy, I always believe they should achieve pregnancy as early as possible, especially when they are married.
So the next step there is it okay? Suppose they don't agree for the cystectomy this time, is it okay to proceed with the next step of treatment, as you said, for IVF or even the first step in that controlled ovarian stimulation, hyperstimulation and IUI or IVF in the presence of this cyst? Is it going to affect a great deal the outcome?
Obviously, where the cyst is, if we don't remove it, that ovary probably is going to be of no help for ovarian stimulation because, I mean, if 7 to 8 centimeter cyst, going, I mean, puncturing through the cyst is always because
very dangerous. Yes.
Borderline tumor at the least. So that ovary in the current situation is not going to help us for controlled ovarian stimulation because we will not be able to access the follicles.
Correct.
So the right step would be to, counsel them. And I think document that we have done the counseling that this should be removed. And soon after that, we should proceed with ovarian, controlled ovarian stimulation.
Correct.
I would say compared to IUI, we don't know with this repeated surgeries,
better IVF. Yes, correct.
IVF would be better because that is the best chance of achieving not only embryo for transfer in that cycle, but hopefully more than that. And if her response is sort of minimal or moderate, I would say, like accumulate some embryos because, in the interim period, she may grow another cyst. It is challenging and it can only happen with them understanding the gravity of the problem, even though it's a benign condition.
Correct.
Otherwise, at some point of time, I think, ma'am, she will end up losing the ovaries and then having to go.
That is what is my worry. She's 27 now. She booked with me when she was around 22, 23, like that. And she got married about a year ago. So I have been having this case over years, and I keep thinking that I'm not doing the best. So I thought I'll ask you. Thank
No,
you, Padma.
I
Yeah,
think it is the best we can do is what, evidence is. And I think it is to document
correct.
because she's very young, 27, and we are worried both from the benign, I mean, whether it is going to remain benign on one side,
Hmm.
why it is recurring, and on the other side regarding her fertility. So,
Really difficult to create a
and
balance.
the thing is, if she, one of the ways is, if we remove the cyst, do IVF and accumulate embryos, and
Yeah.
then give short span of time, short span, like 2 to 3 months, they want to try naturally, because giving clomiphene is very worrying because we know that there is some association, prolonged
Yeah.
use of clomiphene and ovarian tumors. So,
Correct.
if she achieves in that interim a pregnancy, well and good. Otherwise, at least these embryos are there.
Thank you so much. Thank you so much for that. Yeah.
Thank you, ma'am.
Thank you. It has helped me. Yeah.
Sir, your remarks, sir, before we close.
Dr. Padmarika, KSOGA really thanks you for spending so much of time with us today evening. Your presence made us a lot of impact on us. Coming to the four speakers, you have done wonderfully well today. See, this is what I wanted to. The two things. One thing is the youngsters should get the platform. Second thing, the corner part of the Karnataka from Bida, Hassan, Yelahanka, Davangere. I think was it Davangere? No?
Yes, sir.
These are the people. They have come to the platform to give their talk. Your slides were so crazy. Your talk confining to yourself to 12 minutes. These are all the things which really you are the futures of KSOGA. I hope you are the futures of Foxy too. That's what I was wishing. With that intention, I framed this program. And always, once there is a competition, then only the best thing will come out. So that was the concept of having the competition. Once there is a competition, you should have some prize. So this is the ultimatum of this thing. This is what I want to tell to Dr. Padmareka if about the concept of this webinar. I'm really happy, Srimati, for taking this forward in such a beautiful way. And personal thanks to Dr. Jyotika Desai as well as Sundari Madam. Thank you.
Yeah, thank you. It's a pleasure and learning for us also, Dr. Durgadas. It's a very learning event. As Dr. Padma was telling, it's a unique thing you have started. And your objective is too good. That's the way we are promoting a lot of youngsters. And we are knowing the talent of youngsters. That's more important. I think all of these people should be involved in our conferences so that, next generation you are bringing them up. That's very nice.
Lot of potential.
Yeah.
Very good.
Wonderful. They did very well, extremely well they did today. Their slides, their way of presentation,
And they're
their
confident.
subject, everything was too good.
Good.
They are coming to the forefront.
Yes, they should.
They should be given the platform. That was my
Yes,
concept.
they should be given the platforms here.
At the future, Durgadas.
Ma'am, vote of
Thank you,
thanks,
all
ma'am.
of you.
Shobha, ma'am. Shall I say or?
Very Shobha Bumble.
You can do it,
Thank you, ma'am.
Srimati. Yeah.
So thank President, Secretary, Treasurer for having given us this opportunity, and the CRC team, and Jyotika ma'am for being the backbone at every step. Jyotika ma'am and Sundari ma'am for being the webinar series judges, and Padmareka ma'am for joining us today, staying with us for the full webinar and also giving the expert talk. Really, your presence is very much appreciated. We are very grateful, ma'am. And of course, for those four speakers and their societies, Dr. Varshita from Davangere, Dr. Deepthi from Yelahanka Chikkabalapura Society, Dr. Bhavya from Hassan, and Dr. Sangeeta from Bida. Thank you very much. And of course, a KSOGA team, the man behind everything, Mr. Arun. So thank you very much. And all the delegates who have joined us. It's really a great pleasure. We are going to bring out a newsletter. So the previous month's newsletter is going to come out shortly. And this month also, we are going to do a newsletter. So we request all the speakers and of course, Padmareka ma'am also to give a short write-up so that we can bring it out as a newsletter so that people would be benefited. And please watch out for our next webinar, which is going to be on the 8th of July, again Tuesday. So every second Tuesday, 5 to 6:45. Please mark your calendars for the webinar, Controversies to Consensus by the Clinical Research Committee. So thank you very much, sir. Thank you, everybody. Thank you, sir.
Thank you very much.